And finally, we've made it to acute and chronic injury drugs or medication, pharmacology. I'm getting more and more exhausted with each video I make, so if I'm starting to sound a little nuts or making minor mistakes here and there, that is why. I will try to focus really hard on not doing that, so that I mean, the purpose of all of this is that you guys have a basic understanding enough to pass an exam. You know, I'm not by any means like, you know, all knowing, or I just know that I managed to get very high marks in this course. So I'm teaching you what I know. Hopefully it's okay. So let's just go through this really quickly. Vitamin D, we've actually talked about, haven't we? A lot of this we've talked about, so this should be a quick video. If you don't know why, go back and take a look at the other videos, but we will give vitamin D. Here are some foods that have vitamin D in them already. You can also get a lot of vitamin D from the sun. Okay, moving along. I think we have talked about all of this. So this is just kind of breaking down how the kidneys activate vitamin D. There's a really fairly not complicated, but like a feedback type relationship between vitamin D, calcium, phosphorus or phosphate, still don't know which one, and calcitonin and the parathyroid hormone and all of that. For this course or this unit, I really don't think you need to go into all of that. Just understanding that vitamin D is what helps to activate the absorption of calcium in the GI system is really, really important. Oops, sorry. Again, calcitrol can be given to increase the absorption of calcium in the GI system, and that's treating hypocalcemia. Sometimes it can also be used for hypoparathyroidism or hypophosphatemia, and that's because it actually increases the absorption of both calcium and phosphorus through the GI system. This here is if this isn't working, your body isn't creating its own calcitrol, so you will need to basically have synthetic or have some given to you. Contraindicated, obviously, hypercalcemia, kidney stones. This is because kidney stones are often made up of that calcium phosphate kind of crystallization, and so we need to be careful with that. We don't want to give it if the patient is hyperphosphatemia. To be honest, I've never ever given this, so it's a little bit. Yeah, I've just never given it. I've given a lot of vitamin D, a lot of calcium, and that's usually enough. So just maybe go through this slide, but I think it's more important to understand the relationship between that feedback system and that whole idea of vitamin D activating the absorption, or activated vitamin D encouraging the absorption of calcium and through the GI tract, right? So that's really the important thing here. So you can go through and just understand that you can sometimes have some adverse effects, but they're very few. They're not major. I wouldn't necessarily worry about that. You're going to monitor renal status, of course, nutritional status, of course, and you're going to monitor for any adverse effects. One of the effects actually that does happen is tasting metal in your mouth. Okay. Okay, there are medications that will stimulate erythropoiesis, which is the process of the production of red blood cells. So, one of those is, they've got it here, darbepoetin. It basically stimulates that red blood cell production. It doesn't work right away. So it's awesome if the reason you're anemic is that you it means that your erythropoiesis process has been compromised. So for example, in chronic renal failure, right? And again, with the anemia and renal failure, it takes, with acute kidney injury, it usually happens very quickly and is dealt with very quickly. So you don't necessarily have time to develop the anemia. That's why it's more highly related to chronic renal failure, right? Whew. Outcome, decreased anemia. Great. Uncontrolled hypertension, I'm guessing. So I don't know this. My brain is saying creating more red blood cells would increase the blood viscosity, increase blood flow, and would therefore cause hypertension. And so we want to be careful not to give it to someone who already has uncontrolled hypertension. Side effect hypertension, headache, fatigue, muscle pain, nausea and vomiting. These are all transient. So basically when you start taking the darbepoetin, you might have them, but once you've taken it for a while, you don't get them anymore. This is just another erythropoiesis stimulating agent. So we don't want to give it both because you're going to have a lot of red blood cells, right? We don't need that. You can have an allergic reaction, but it's usually just that shows at the injection site. So you want to watch for that. Anytime you give a med sub-Q or IM, that's one of the things you're going to watch for, right? Is any kind of reaction at the site where you give it. Calcium carbonates, we give this quite a lot, basically to supplement calcium when you're hypocalcemic. People suffering from osteoporosis, we will also give them that. And if you have hyperphosphatemia, usually that means you have hypocalcemia, not always, but usually. And so you will, calcium will actually treat the hyperphosphatemia by increasing the calcium. Okay. This all makes sense based on what we've talked about. Yes, flatulancing. Yes, constipation. Sorry. I'm so sorry, guys. It does interact with thyroid medication. We would still give it with a calcium channel blocker. We would just keep watching to make sure that it's working as well as it was. Thiazide diuretics, one of the side effects is that it increases uptake of calcium. So guys, these kinds of things here, these are minutia. So I just wanted to encourage you to really focus on the disease process and all of that stuff and not get bogged down by the minutia of the pharmacology. These are things that every nurse forgets and has to look up, and most people aren't going to remember through their entire career that this, a thiazide diuretic increases hyperkalemia, right? Like it's just I just don't want you guys to get too bogged down. We're at the point now where you understand the vast majority. If you've gone through the videos and you get what I'm saying, hopefully I'm saying it right. If you've done that, you get the vast majority of what you need to know. Okay, so don't panic at trying to remember all the minutia of all these things. Obviously, you're going to monitor calcium levels. So what you might get asked is, you're giving, let's say you're giving calcitrol. What should you do? And then one of the options would be monitor calcium and phosphate levels, right? And so really they just want to know that you kind of have an idea of what that drug is for. The chances of them asking you if you should take it with a thiazide diuretic are pretty slim. And definitely, I can't see that being like an NCLEX question. And then the last, I think this is the last med, yes, is K-oxalate, your sodium polystyrene sulfonate. This basically removes all the potassium from your body, well, from your bloodstream. It's to treat hyperkalemia. It just gives you diarrhea, and really a lot of diarrhea. It's really terrible when we give it in Emerge. I always feel really bad for our patients. Outcome, decreased potassium level. So I was always taught that it gets rid of all of your potassium, like all of it, but that's one of those things where my common sense is just kind of going, can it do that? The point is it gets rid of a lot of potassium. Okay, so we're not going to give it to somebody who has hypokalemia. We don't want their potassium to get any more. This is an important question. This is something that could come up. Why would you not give K-oxalate to somebody with obstructive bowel disease? So you guys haven't gone through bowel obstructions, I don't think yet. But basically, if you have a bowel obstruction and nothing is getting through that system, you do not want to give the patient diarrhea for a number of different reasons. For now, before we go through all of that, because we'll go through it, I think it's like your last unit. For now, what helps me is I just imagine, because K-oxalate gives a really, like a lot of diarrhea. And I imagine what happens if you have an obstruction and you have diarrhea and then it all just backs up. So that kind of is my first thought. There's way more to it, but for the purposes of this test, just think of that, okay? There's a lot of sodium in K-oxalate, right? That's why it's called sodium polystyrene sulfonate. And so water follows sodium, so it can create hypertension, okay? There is sorbitol maybe in some of it, which contains glucose, so you just keep an eye on their blood sugar levels and don't give it with anything else that contains sorbitol. And again, we've talked about this. For hyperkalemia, we're going to use insulin and glucose together, or dialysis, because dialysis, again, is one of those things people always tell me that it gets rid of all of your potassium, but to be honest, it's definitely something to look up, and I'll probably look it up after this video and be like, oh, I should have done that before. But the gist is it gets rid of a lot of your potassium. People who are on dialysis have very low potassium. Scared me the first time I had a dialysis patient, but apparently it was normal. Yes, it can be given orally, it can be given enterally, it can be given as an enema. Yes, it causes nausea and vomiting. Electrolyte imbalances. Anytime you have a lot of diarrhea like that, you're going to have an electrolyte imbalance, and especially affects magnesium and potassium. And yeah, you will have sodium retention, and that's related to the fact that there is so much sodium in the drug itself. Okay, so you're going to assess bowel function. This is all related to the fact that K-oxalate causes diarrhea. You're not going to forget that when you go into the test. Monitor for signs and symptoms of hyperkalemia. We're going to monitor cardiac status because of the effect of hyperkalemia on the conduction system of the heart. We do not want any other laxatives or antacids with it. Obviously, we want a low potassium diet. And we're going to monitor bowel function. Those are pretty common sense things. So when it comes to the meds, we've honestly gone through a lot of it already. I tried to highlight the things that actually mean something, things I've seen come up on tests. So I've taken, I don't know if I told you guys, but I've taken, because of the way I did school, I've done multiple programs. I've taken patho 3 or 4 times at this point. So if I haven't seen a question come up, it does mean something. Some of the stuff I'm saying to you, oh, you'll see a question about this or this, is because probably out of 4 exams, 5 exams, I've seen them on 3 out of 4 exams, right? So I'm just trying to focus on those things because it's impossible to cover it all and to understand it all. Anyway, we are done with kidney, thank goodness. I am going to get started on making some videos about brain injury and intracranial pressure and calculating cerebral perfusion pressure. So I'll get started on that, and happy studying to all of you. And as always, shoot me an email if you have any questions.